Good afternoon, everyone, and thank you for taking time out of your day to join us for our Inter-CFAR Faith and Spirituality Research Collaborative Fall Webinar Series. The title of our webinar today is Faith, HIV, and Mental Health During COVID-19. Before we start with our webinar, we would like to have a moment of prayer with our Pastor Will. Pastor Will Francis, will you please lead us in a moment of prayer?
Yes. Hopefully everyone can hear me. Good afternoon. And I wanted to share more of a thought than a prayer that would just ground us for the work that we're getting ready to partake in on today. And it's just something that I wrote down in my morning meditation that just simply says, we come today from different parts of the country, different backgrounds and different religions of different beliefs. We come today from different races and different genders, different sexual orientation, with unique experiences, personal and professional, educational, social trials, as well as triumphs. We come today, and it doesn't matter the side of the aisle that we're on. It doesn't matter the who, what, where, or when that we put on our ballots. It doesn't matter where we stand today on the issues. Because we're here today at this very hour, at this very present now, with pen and paper in hand to indelibly write yet another entry into our own unique stories which are singular but yet share a common destiny. We are here today in this chapter, in this page. It's where it all sinks. And whether our faiths are grounded in the Talmud, the Veda, the Quran, and the Old Testament, New Testament, whether we read and study ancient or contemporary texts, the entry for all of us today should simply read, "It's time to heal." Amen.
It's supposed to go to Eddie first.
Thank you, Pastor Will Francis. That was very inspiring and very powerful. But the main reason we're here as well is the Inter-CFAR Faith and Spirituality Research Collaborative. We are pleased to announce our webinar, which is the Faith, HIV, Mental Health During COVID-19. This webinar will explore the traumatic experiences of living with HIV during COVID-19 and how the faith and spiritual communities can be a source of strength and support. The panelists will share from a variety of different perspectives. And now our panelists. Thank you. The first panelist again would be Pastor Will Francis. Pastor Francis is the lead servant at the Hub. He's the director, the movement director, and he is the Church Network Dean of SOMMA, the School of Ministry and Activism Chair, the Atlanta Faith and Action in Atlanta, Georgia. Again, welcome, Pastor Francis. Wahida Shabazz Oz, she is community trainer, HIV and faith consultant, founding member of the Positive Women Network USA, interim program director for the Reunion Project, member of the Muslim for Progressive Values and the Unity Mosque, Toronto, Canada. Also a board member of Cyril Project, the Goodwood Ambassador, Philly Fight. Again, welcome Shabazz L. Next, we have Dr. Musgrove. Dr. Musgrove is the CEO of Birmingham AIDS Outreach, the Magic City Acceptance Center, the Magic City Wellness Center, and the Magic City Acceptance Academy. And I must say, the Magic City Acceptance Academy is the only Magic City LGBT-friendly academy in the state of Alabama. Congratulations, Dr. Musgrove, and welcome. Quentin Bell. He's the co-founder and executive director of the Knights and Archers Society. He's the co-chair for the Center for Black Belt Equality Transgender Task Force member, National Training Institute for Trans and Gender Nonconforming Leaders from Selma, Alabama. Again, welcome, Quentin. Last but not least is Dr. Watt. Dr. Watt is professor of the Department of Psychiatry and Biobehavior Sciences, UCLA Selma Institute for Neuroscience and Human Behavior, director of UCLA Sexual Health Programs, director for Center for Cultural Trauma and Mental Health Disparities, also associate professor, a director, UCLA AIDS Institute in Los Angeles, California. Again, welcome, Dr. White.
Thank you.
And I'll be sharing this webinar with my co-chair, and that will be our elder, George. And he will talk about the overview of trauma-informed care. Elder George.
I'm really happy to have Wahida to really talk us through this. It's spending about 5-6 minutes on the overview of trauma-informed care and why it's so important that we have this conversation with our faith community. Wahida?
I'm unmuted. Hi, everybody. Good afternoon. I believe we're going to run this. Someone's going to run the slides for me. Okay. So trauma-informed care at the broadest level, it just means services that have an awareness and a sensitivity to why the client that sit in front of you, the kind of services that they need to be understood in the context of trauma history. And many of us have trauma history. And these people may have different entry points. They may come to a medical provider for services. That's an opportunity to provide that sensitivity and that awareness. They may come to a mental health specialist, or they may come to a faith institution. They may come to a community-based organization because they need help with LAHEAP. They need help with utilities. But at every entry point where we can do this trauma-informed sensitivity, that means an assessment of not what the physical person you see in front of you, but what has happened to this person that has brought them to this point. It could happen in a recovery program. It could happen in youth programs. It could even happen to people who are being incarcerated as they also do an intake. Anywhere there's an intake being done, there's an opportunity to have that awareness and sensitivity and give the service based on the trauma that comes out of that interview. We can move on to the next slide. Thank you. So trauma-informed care, a lot of times we call it TIC, and it uses an approach that has three principles. There's more than three, but the three major principles: people have to feel safe, physical safety. They have to feel psychologically safe, and they have to feel emotionally safe. These are the components that creates opportunities for the survivors, like to rebuild their own sense of self-control and empowerment. So as we bring people in to do their intakes, we want to make sure that people are feeling safe, that they're feeling like everybody's here is there for their goodwill, and they have a feeling of goodwill and emotional safety. Yes, if you can move on. I just want to share just a few what I like to call jewels. A needs assessment cannot be based solely on the physical condition of the person that you see sitting in front of you. We have to remember that this is trauma informed, that there's more to what we see sitting in front of us. People want you to fix them. They're there because they want to be fixed. So we have to make sure that we don't ask people what's wrong with you, but we have to learn to ask people what happened to you, because there's something that happened before they got there. Another thing we want to do that may seem very, as far as physical safety, there may be different ways that they can enter the building. Everybody doesn't want to walk through the front door of the building if there's another entrance, especially for people of trans experience, because they're ridiculed and at a higher level than most people are. And a lot of times there may be if there's a different entrance, that would be a way of trauma-informed care, just making them feel physically safe. We have to be mindful that we are not misgendering individuals. It doesn't matter what they appear or how they appear. It is our duty. It is our responsibility as being sensitive and being aware of trauma. These people have already been traumatized. We want to ask people, what are their names? We want to ask people, how do they identify? What are their pronouns? And not what are, and we never ask, what are your preferred pronouns? Because that's an insult. Because to say what is your preferred pronoun says, okay, this is what you prefer, but I'm thinking you're something else. So we want to make sure that we're using people's pronouns that they give us and we're not misgendering them. We want to make sure we're using people's first language so we're not stigmatizing people. We always put the person, humanize the situation and not put their problem or their condition ahead of who they are as a human being. And a lifetime exercise, a lifeline exercise may be helpful. And I think I have a few examples of what that could look like. So if we can move to the next slide. Yeah, so a trauma-informed timeline. And a lot of times with women then with HIV, we end up doing this. We kind of put the ages from 1 year old all the way up to 65, who's ever in the room. And we ask people things like, how old were you the first time you walked to school alone by yourself? And many people may have that same experience at that time. When was the first time you drove a car? So, and then we just kind of build up the things that may not be uncomfortable. What's the first time you had unconsensual sex? That means you may have been touched. Maybe you were sexually molested or something, because consensual sex and unconsensual sex is two different things. What's the first time you experienced violence? It may be violence to yourself or to another individual that you may have experienced. That impacts us when we experience violence. When's the first time you had consensual sex? When's the first time you had your first kiss? And then we ask the harder questions like, when did you receive your HIV diagnosis? And not only when did you receive a diagnosis, when did you receive treatment? Because a lot of people will get an HIV diagnosis, doesn't mean that they're ready to go into treatment. So these are just examples of some of the questions that can go across the trauma-informed timeline, and people will find the patterns, and they will be able to see for themselves just kind of where things kind of just start going array. Right? And so maybe we're able to pin down how we can help them. So we could just move to the next slide. I think I have 2 more slides. Okay, and so one other thing we ought to be mindful of is maximizing the time. If we take a minute to do deep breathing, the pastor earlier, instead of prayer, he took a moment to do meditation. That's a grounding sort of exercise. If you're the person who's creating the timeline for the person, then you have it's not about having time, it's about making time. Clients feel safe when they know that you see them. And sometimes we have to make sure that we let the client know that this time is for them. And clients will be more receptive to absorb the information that you're giving if we just take a step back and just breathe. Just breathe. And I got this from some evaluation. This is the best practice. We do a lot of webinars with long-term survivors of HIV through the Reunion Project, and through our evaluations, people always express that grounding before we get into the real nitty-gritty is always feels good for people. And my last slide is just something I wanted to share with you. If you move to the last slide, this is just something that I don't generally promote research, but in this time of COVID, I have found that I have been a big promoter of research of studies around depression and HIV. So I'm working through the University of Penn, CFAR in Philadelphia, their behavioral and HIV department, and I've been promoting studies like these for people living with HIV, and I've been promoting them at food shares where people go. People are going out to get food now because it's just the time we live in, and so particularly at places like that, food shares, places that people are getting free donations and household goods. I kind of bring these out. So I'm going to end there and go back to the rest of the panel. And I hope that if there are any questions, I'm happy to have questions somewhere, wherever they tell us to have questions. Thank you so much.
Afternoon, everyone. I'm Elder George Kerr. I've been thriving with HIV for 25 years, and I've been doing a lot of work with the CBOs Community Advisory Board, talking about research and the faith community. I am a clerk of session with Westminster Presbyterian Church in Southwest DC, And I just want to thank Wahida for that incredible, powerful opening to ground our conversation on what we're going to be talking about this afternoon. So if we could bring up the questions, please. What is the faith-based community-specific role on people's mental health issues during a pandemic, and how engagement with religious groups help fight COVID-19? And Pastor Will, can you open us with this?
Sure. I think we definitely have a specific role when it comes to mental health, period. Of course, it is heightened because of the pandemic. I know historically that we have sort of just had folks to pray things away, and we know that has led to not only church hurt but also religious trauma. So we do definitely have a specific role within with mental health issues. Here at the Hub, we focus on not only trauma-informed care, but really have taken what's called a healing-centered approach, where we just sort of approach it just a little bit more strength-based and holistically with issues that we have with folks coming in. But I think it is very, very important that the faith community allows spaces for mental health. We have healing groups as well, where folks can come in and participate in healing exercises, et cetera. So that's what we've been doing. But I want to encourage faith-based leaders that they do, if they do not have a role currently, that they identify a role, partner with a community-based organization, whoever, and really focus on mental health issues, because it is definitely, I think, as Wahida said earlier, we see an uptick with mental health issues just going through this crisis.
Wahida, would you like to add to that? You're muted.
Faith has a role in healing from whatever we're recovering from. Now, I need to say, if you live long enough, you'll be recovering from something. And one thing that I wanted to add is that when we're as faith leaders, we have to make sure that we're not adding unintentional harm to somebody who's already hurting. So our job is going to be to make sure that we always humanize. We know we're not here to be perfect. We know we're going to fall short, so that we're humanizing whatever the situation that we're there to help with. And I just want to add that if a person comes to you and they are using intravenous drugs, then they don't become an intravenous drug user. They become a person who uses drugs. We have to always make sure that we're putting the person before the condition that they're there to be treated for.
Thank you. Quentin Bell?
Some really great points made by the other panelists. I just wanted to touch on what Wahida and what Pastor Will was saying earlier about, one, addressing the church hurt. For me, being a black transgender man, sometimes the church isn't the easiest place to go to get resources, but sometimes the church has access to resources that we can't really get any other place. So I think, like Wahida was saying, faith has a part in healing. You know, it's just a part of the healing, and really focusing on and making sure that you're not re-traumatizing people, especially in a time like this where mental health in the South is something that we're not able to readily access all the time. And then the stigma around wanting to access, it takes a lot for a person to get to a point to even to ask for some help. So understanding that we do have a responsibility as faith folks and as community organizers and community-based organizations to make sure that we're making spaces safe and affirming, so people can reach out and get the help that they desperately need, particularly in times like these.
Thank you.
If I could just come back and just add something, George.
Okay.
Because I want to talk about just a personal experience that I've had with the mosque. I know we're talking about the church, but we're talking about places of faith. In 2003, when I was diagnosed with AIDS, and I shared that information with a couple of the women in the mosque, they question if I should even be in the mosque. They question my suitability to not just be in the mosque, but should I be able to pray amongst the other believers? That was one of the most hurtful moments of my entire life, and it took me years to be able to come back in congregation, right, with other Muslims. So we have to be very, very careful. I thought in sharing it that I would get some relief from my pain, but it caused me even more pain by sharing that. So I'm just agreeing with Quentin. Sometimes our places of faith, and I don't think they mean it, but sometimes, yeah. So that's why we're having this webinar. Thank you.
I just have to add, as a gay white man, I've experienced a lot of hatred within the church as well. So it's not based on anyone's race, sexual orientation. It's just the way the church has been and needs to grow. So I'm going to move us to our next question. How has COVID-19 affected HIV prevention and treatment in faith community? And let's start with Dr. Wyatt with this one.
How has the church affected the community?
How has COVID-19 affected HIV prevention and treatment in the faith community?
I think that the devastating effects of COVID have made any kind of stigma that people might have been burdened with even more challenging, because it has separated people and isolated people who really need the faith community. They need social opportunities to intermingle with individuals. And because of the COVID restrictions, masks and gloves and distancing, for example, it's very difficult for some organizations to have any kind of physical opportunity for people, which has really made it very difficult. In my research, we have found that individuals really responded to our efforts to give them tablets, and we give them tablets to participate in groups so that they can be safe, everyone can be safe, and they can enjoy the groups without having to risk becoming infected in order to make some sort of in-person showing at a church or a community organization or a mental health clinic. It's taken more of a financial commitment, but what it's done is to open up that individual's world. They can get email, they can be reminded of appointments, they can have social reminders and religious messages sent to them on a daily basis just to keep them, keep their spirits up. And we first got a lot of resistance from the government about wanting to give individuals tablets. We even gave them hot spots. This is Wi-Fi, because some areas don't have good Wi-Fi. So I've had a whole education on, you can give a person a tablet, but if they don't have the connections, it's not going to work for them. Then we had to teach them how to use the tablets. But in doing so, in taking that time, and we taught them how to use the tablets on a tablet. It's really been an education for our team and for the individuals in our intervention groups. And I think it's brought us all closer together, because we had to develop instructional videos that weren't appropriate. The ones on YouTube were not appropriate. They weren't diverse enough. So we really wanted something to make people feel very much included in the whole process of reaching out. And I really want to stress this to the religious community. Sometimes it takes something very innovative and very different. I don't expect that in the future, people are going to come to church the way they used to. They are not coming now. And I think that religious people need to really think about how they can get out of their space and reach out into the community, so that individuals don't feel left out by the religious community because of COVID, but actually the religious community is reaching out to them in different ways. And I do think that asking for donations so that tablets can be bought, and then individuals can learn how to use them with assistance, opens up a whole new way of communicating with one another through interventions, through religious messages and social messages, just every day checking on individuals. So this is really, I think, enhanced the research that we're doing. We were doing research before COVID. We had to stop. We had to go through IRB and convert everything we were doing to virtual methods. And now we're doing research virtually with tablets. And the populations that we're serving are very excited because we never abandoned them. And I think it's terrible if religious people cannot find ways to reach people. So we have to really think out of the box and demand, and it's literally demanding that we get more funding from some of the large CFARs in order to do this kind of work. We can't just operate as business as usual and expect people to respond in the same way. We need to understand that you have to reach out to community, and our communities, the Black and brown communities, people with different sexual orientations, people who have chronic illnesses, want to be safe. They stay home, but then they can't benefit unless we give them tools to reach us, and then we reach them.
Those are some amazing points. I know that my place of worship has moved to virtual Sunday service, and then we have our Wednesday night, our meditation night.
Yes.
And that. So those are really good points. Yes. Dr. Musgrove.
Yes. I love all those points, and I love the idea about having the iPad so people can be engaged. So I'll just add to that. We had to change the way that we were doing prevention and treatment for HIV and also testing. So when COVID first hit, of course, we stopped our testing and our prevention and then opened it back up in 30 days. And we created take-home testing opportunities and testing so people can come and get a packet and take it home with them. And we had to teach them how to do the swabs. So everything that we're doing right now for COVID has had to change. But I think a lot of it is actually good. And you're right, we will not go back to how we were. And I don't think that's a bad thing. But we have been using a lot of resources in the community, including the faith-based community, to keep people engaged. I think people feel very isolated right now, and the faith-based community has got to keep people engaged and think of creative ways to stay engaged. So I'm very happy with the changes that we have made and how fast we made them. But I do know that we've left a lot of people behind that we can't see. We can't see them anymore. So that's just one thing that we're constantly struggling to catch up with. And I love the iPad idea. I wish I could give everybody an iPad. That would be amazing.
You can.
It's a good goal. Well, it's a great idea.
And you buy in bulk. There's what, you have to make deals in order to get them, but you can do it. We just haven't asked. We haven't asked some of our larger donors, corporations, how much money can they give us if we can reach 500 people? And believe me, you can reach people you couldn't reach in person, because some people will not come out. Maybe they haven't come out for years, but now they have a way of being able to participate in Sunday services or whatever day services without putting themselves at risk or anyone else. So really, if you can think beyond what money's coming in to really get that ask to a larger corporation to say, you can help us to reach people in ways we've never reached before, and we will put up little logos of yours to let you get the visibility. And thanks for having reached out into our communities. This is what we need today. This is 21st century intervention equipment. It's not just talking. We've got to reach people, or else we're not going to be able to teach them the skills that they need to reduce their risky mental health and physical health behaviors.
Exactly. We have a youth program, and since COVID, we've moved all of our programs to an online platform, and we have actually seen the number of youth involved has actually increased significantly. So we are actually reaching youth who live too far away, or maybe live down a red dirt road and can't get to our programs. So I think the faith-based community can also grab onto those as well, and then also integrate themselves into programs that are working. So
absolutely.
Okay, we're going to move on to our next question, and this is where my heart is, talking about harm reduction. How do faith-based organizations support the mental health of substance use disorder? And I know Dr. Will, Pastor Will, this is one of your areas of passion. So why don't you open us with this one?
Sure. To Dr. Wyatt's point, our ministry actually does well without walls. We haven't been in 4 walls about 5 years now. So COVID threw us a curveball as well, because we didn't know how to not only protect ourselves, but then protect the 50 or 70 people that were coming to our various multiple sites that we were doing outreach. I sort of have a reputation throughout the country for a while of doing communion and condoms. And now we actually do communion, condoms, and needle exchange. And it was a huge bend for me. Once I understood harm reduction, and it goes back to what Wahida and Quentin said, that the faith-based community cannot afford to do any further harm. And a lot of my colleagues questioned me on why I would give needles, to those that were using substance. And we have story after story after story of the relationships being established with us doing food, hearing a message, prayer, different things of that nature, and you're getting clean needles from us. Well, it just so happens that when they're ready to get off of substance, they then come back to us and, can you help us get in a program? We support them throughout that program, doing check-ins, different things of that nature. When they come out of the program, they then come back to us, because we have the relationship for further support and spiritual care and counseling. And we had one young lady engaged in sex work. She used substance, went through a program, graduated program. We helped do workforce development, job readiness training with her. She got a job. She's doing extremely well, just moved into her own apartment. We helped her get a furniture through the local furniture bank and some stuff that we had in reference to donations. And we just gave her a car not a month ago. So
that's wonderful.
That we really want to focus on the whole person.
That's right.
I think faith-based has, and I just want to use, in the context of faith, we want to focus on the sin and not the person, right? We get just so focused on, like with HIV, we have to know, how did you get HIV? Right? But we don't ask that question with diabetes, like, was it pie or cake? Or if they say, I have high blood pressure, what was it, ham, pork chop, bacon, or whatever? But with HIV, we get so entangled in the religious piece of it. But when we focus holistically on the person, we can see just transformation throughout. So George and I have had many conversations about the work that we do. And I think this has been one of the most rewarding ministries that we have, because we can literally, see each stage and that journey, the progression from where they are to where they want to be, and the faith-based community being a part of that.
Well, I'm so delighted to hear you say that you've got a program that allows people to move beyond needles into some other kind of training and skill-based method of giving them options for another life. Because one of my first issues with needle exchange and some of the harm reduction programs was that they stopped right there. And they did not offer individuals an opportunity to learn other things. I like the fact that you are always encouraging them. When you're ready, please come back. Let's move on to the next phase. This is not where you're supposed to be. And I think that's extremely important for us to continue to let people know that where you are now may be enough for you in this moment, but it is not what you're intended to do. You're not in this world just to get a clean needle. You're in this world for a purpose. Let's get to it. And when you're ready, I'm ready for you. And I think that's what my resistance has been, that people don't work hard enough in the Black community with a homeless person who's just exchanging needles, and they're living on the street, engaging in sex work, engaging in a lot of other harmful and risky behaviors. And we consider that a success. I wouldn't consider it a success until we can get that person off the street. I'm dealing with mothers and children living on the street and trying to place them while we have the mother involved in a risk reduction program that teaches her not only about harm reduction, and that's not enough. She's got to move on. We're teaching women who are 40, 50 years old about their bodies for the first time. One of the problems that we have with HIV interventions, and particularly those that are aimed towards people of color, is that we don't understand the history of sexual exploitation in this country. And that we consider, because most of the interventions have been developed on gay white men, that everybody knows about their body, how they get infected, and just exactly what they should do in order to stay safe and healthy. And I think that we need sexual health education in the church continuously, because someone's always growing up. And when you get to the point where you're at least 10 years old, you ought to know where babies come from, what are the proper parts of the bodies, what are their names, how does the body work. That's for a male or female. Doesn't matter what your sexual orientation is. It just means that you are educated about how the body works. And I think it's extremely important for us to realize we need different information than what is available now. You can get tons of information about vaccines and what you should get and methods of use, but we don't go back to the basics in our own community to make sure people know what is sexual exploitation. Some people don't even know that they're being raped, or they don't even know that they're being exploited. So we need a different mandate and a different way of understanding that until we get this information through generationally, we will not see the changes in our community that we might see in another community that has had access to this information all along. And that's for anyone, regardless of sexual orientation. We all need to know about our bodies, how they work, and how to keep them safe and healthy.
Thank you.
Thank you. I would like to add something to that. Yeah, I want to just talk about the power of words and how much power words have in them. And as people of faith, and if we're supporting people with substance abuse, mental health, these are conditions that have a lot, that are affiliated with a lot of stigma. And so we have to make sure, again, that we're using people first language. I talked about that already when I talked about not referring to people as these are the intravenous drug users. No, these are the people who use drugs. And the same thing with HIV. I've seen a lot of places that want to open up HIV ministries. And I always push back, because I would prefer to see you open up a ministry for people with HIV. Right? Because to me, once you say HIV, it doesn't matter. Once you say HIV, people don't hear anything after that. So I keep telling people, stop saying HIV first, because once you say it, people shut down. They go to that place that Pastor Will Francis just talked about, wondering about how did you get it, right? So you already lose them. So we're dealing with people with this stigma around getting mental health treatment. There's stigma around being a person who uses drugs, and there's definitely stigma around people who live with HIV. So I just want to say that we know God works through people, but the devil also works through people too, right? And so we, as faith leaders, we just need to make sure that we are conscious and know what our motives are, why we're doing this work, why we're trying to help these folks, right? And also allow those people who are part of that program to help develop the program. It's called meaningful involvement of people who are most impacted, because even with our best intention, we could miss the mark. So a lot of times we have to have those people as a part of how they not just help develop the program, but how do they evaluate the program, whether the program's working or not.
I agree.
I like you too. I want to study up under you.
I just wanted to chime in and just kind of piggyback off of some of the amazing points that have already been made. I've been sitting here jotting down so many things, trying to keep up with all the knowledge that's being dropped. But one thing that really stood out to me is when we were talking about the lack of sexual health education. I know adults who don't know language. I know adults who aren't educated about our own bodies, and particularly being a person of trans experience, one of the most difficult things I had to deal with was dysphoria, and not even liking my body and coming to terms with loving my body when my gender identity didn't match. So it was definitely harder for me to really find that necessary information. And I think Dr. White, it was you who brought up the point that even when you do find that small bit of information that is available, you look at it and see that it's not reflective of who you are. It doesn't directly, there's no direct connection with you. So one of the things we started to do during COVID-19, because our state, in a sense, completely shut down, and Alabama was solely focused on COVID-19. And I feel like the amount of sexual health education and prevention work that was happening drastically changed. I know we shift being Alabama's only Black trans-led aid service organization. Even we shut down for a minute and started focusing on making sure people had food, making sure people had housing supplies. Our stores were out of tissue and basic household cleaning supplies, and our partner Yellowhammer Fund was finding ways to purchase it in bulk and ship it down to us by the van load, so people could have basic supplies. So there were a point, I know, at least 3 or 4 months in Alabama where there was no talk about sexual health education. There was no talk about testing and prevention. And I'm a young Black man, and I understand that sex is 3 things. It's fun, it's free, and you can do it all the time. It's not something that requires you a lot. But in a pandemic, people weren't being tested. I know people weren't being tested like they should have. So that was a major opportunity for us to intervene. And what we decided to do was to start creating those curriculums that we know we didn't see ourselves in. We're currently working on producing a queer sex ed comic book, a small pocket-sized magazine that one chapter of it starts with consent. Understanding what is consensual touch, and what is understanding that also consenting to sex is not consenting to pregnancy. Also arose even in Alabama, where we're having to talk to organizations to include trans people in the talks around reproductive justice. Understanding that you can't do reproductive justice work without including your trans people, and how that should be a part of your work as well. So just wanted to reiterate that there's so much work to be done around making sure that sex education is available to folks. But while we have so much extra time, while we have access to all these additional virtual and online resources, it's a good time to start shifting and thinking outside of the box about how you're reaching people. And with so much time indoors, we no longer can use the excuse that we don't know how to do it or we don't have access to the things. This is a time now to think outside of the box about how we're going to be reaching people. And not being afraid to continue to march on in a way that not to blaze a path that people haven't seen before, because it is so innovative. I remember trying to get our state to jump on in-person the home test kits years ago, and Alabama kept saying, we're not ready. The test kits have to be face-to-face. And I'm like, well, virtually is kind of face-to-face. There are ways to do things, but just making sure that you have to be in a place where you have the support that's also going to allow you to be able to get those resources.
I just want to add that the CARE Act funds and more stimulus assistance for small businesses and nonprofit money's out there to fund some of these innovative ways of us pulling together. And Pastor Will talked about condom distribution and needle exchange in the church. My church was one of the first ones in Washington, D.C. to do needle exchange. But we've taken it to a next step, and now we offer Narcan nasal spray for those that are overdosing. And so we just have to be really innovative when we talk about these things. Let's go to our next question, please. What is the role of organizing COBs and FBOs, community-based organizations and faith-based organizations, in addressing trauma-informed care? So we're kind of bringing this back kind of half circle now. So, Wahida, would you like
to start? Okay.
Please.
Okay, I'll go first. I think that it should be the top of how we provide services and work with our patients and our clients. As Eddie mentioned, we are actually opening the Magic City Acceptance Academy in the fall, which is going to be an LGBTQ affirming charter school. It is going to be based in trauma-informed care first, because it's like somebody said, we're meeting the students where they are. So we really have to look at our patients and our clients and the students and those we're going to serve, and understand that they are coming to us with stories and a lifetime. And until you have counseling and services that really take care of the trauma and the issues that they're working with, we can't expect them to embrace their medical care or their education. So addressing and understanding what is trauma-informed care, I think, should be at the top of all of our list. So.
Thank you, Dr. Musgrove. Wahida?
Yeah, I was going to add to that I'm back to this needs assessment again, and I want to say we need not follow. We have to follow the money, but we also have to make time to be able to allow people to tell us what happened to them. Some people are suffering with memories from being sexually assaulted, as young children, or some people are just suffering from, some people just simply need grief counseling. We lose our parents, we lose our siblings. And when we kind of get those things in place, in addition to the service that we're giving them, we get a more holistic result. We get a better result because people come to us to get fixed. They're coming to the clinics, they're coming to the churches and the mosques, they're coming to the youth centers, they're coming to the CBOs. They're coming because they want somebody to fix them, right? And sometimes we have to do surgery, not just a bandage. Sometimes we got to do surgery, and surgery takes time. So for those of us who are able to or time managers who are able to manage time, we need to make sure we have time. I just wanted to say this, even those of us who are doing webinars, at the Reunion Project, what we've done, we're about to do a 3-hour webinar next month, because we have to have time for people to talk to each other. We have to create time. We have to create the space. We have to create the safe space where people can talk to one another, and we have to create space people can get centered and grounded enough to be able to interact, so that the communication is a multi-directional communication. It's not just a person at the front of the room just giving people information, but there's actually a multi-directional communication. So I think time is something that we can manage. And I think that when we go into CBOs, and a lot of times when you go to see a medical provider, they have I think they're supposed to get 10 minutes with them or something. You're in, you're out. I keep my medical provider in there. I've had them taking pictures of me and take a picture of this and show that to me now, and like that, right? But we just have to, for those of us who are able to manage time, we have to make sure that we're managing time. Like I said, we don't have to have time, but we can make time.
Those are some great points. And I have to really speak highly of the Reunion Project. We did a Reunion Project here in DC last June, and it was simply amazing. We had over 100 long-term survivors coming together for a day-long conversation on what our needs are. And so I would to ask Reverend Will you address the question? What is the role of organizing CBOs and FBOs in addressing trauma-informed care?
Was that directed to me? I'm sorry.
Yes.
Well, we do trauma-informed care. We allow folks to come in and to do the trauma-informed care. Our role as a church, though, is again on the holistic healing piece. Trauma-informed care really involves what happened to you, and we're trying to find out what happened within the community and the family with healing-centered engagement. So we've sort of just shifted to allow folks to come in to do specified, counseling or whatever that they need to do. And then as a church, we focus on holistic healing within the community. We have several instances where it may be, someone 13 that has been inappropriately touched, sexually abused. We find out that it's been the mother, the grandmother, and it winds up being generational. And so we're very, very deliberate in making sure that we try to heal community and the family. So, I fully support trauma-informed care. We've just sort of shifted to the healing groups because that's more of our lane. And we have other folks to come in and work on individualized trauma-informed care.
We're going to go ahead and go to our next question. What is the impact of COVID-19 on the mental health of people living with HIV? And Dr. Wyatt, can you start us with this one?
Well, I think that COVID has just made matters worse, but it creates a challenge that we have to address. Many people with HIV have, as we know, health and mental health problems. One of the, I think, shortcomings of the work that's been done, almost 40 years of work, without any mental health outcomes being reported. Success on interventions, success on medications with no mental health outcomes. I don't think that's progress. If people are not mentally healthy, they are not healthy. So we have to accept the fact that we have to understand the mind and the body connection. It goes beyond what some people have been focusing on in HIV work and in their interventions. So we know that people with HIV have and are more likely to have had histories of trauma, histories of family disorganization, coming from chaotic communities with very little family or community support, lack of education, lack of health, just general health knowledge in order to be proactive and not to wait until a person is deathly ill in order to go to the doctor, knowing how to talk to the doctor. All of these things are impacted by COVID because we can't see people directly, and most services are being delivered virtually. It's made it more difficult for people to address and to learn to identify symptoms of depression, symptoms of post-traumatic stress, high levels of anxiety. And we have interventions now that are helping people to address these things from their homes, learning how to reduce their anxiety with mindfulness, with we call it lotioning, where people learn to rub their arms when they are very anxious. It's kind of a way of tactily calming oneself down. We have any number of strategies that have worked in other interventions. Dr. Cheryl Grills from Marymount University is one of the people contributing to our interventions. She talks about empowerment, and empowerment is a way of learning about your history as a people and how your people have handled some of the challenges that they went through in their time, which gives people courage and determination to see that they too can learn to overcome the challenges of this time in terms of their mental health. But we also have to understand as researchers that identifying mental health problems and talking about them openly in the community is not socially acceptable. There was a time 400 years ago when people who were enslaved in this country had mental health problems, but when they did, they were sold away. And that established a distance kind of an approach to people wanting to admit that they were ill, if they were ill. Some of the diagnoses that were given to them were very racist and very misinformed. Drapetomania, for instance, was a psychiatric diagnosis of a person who kept trying to escape. That was a mental health problem in those days. So it's just so important that we understand the history of how mental illness has been treated in this country. It's not a good message. And it's not changed a lot when we see people who are very uninformed about the history of oppression and mental health problems and how they've been treated, or what people normally do when they have a problem is to use drugs. So this is all connected, and just to treat one outcome alone doesn't give you the sense that you really understand what the mental health problems of that individual are, and if they've ever had anybody pay any attention to them. We don't focus on DSM-5 diagnoses. We focus on symptoms. That means that if you have symptoms of depression, we teach individuals how to handle those symptoms. They may never see a doctor. They may never get a diagnosis, and they don't need one if they learn before that. What do you do when you feel so sad that you have trouble getting out of bed in the morning? What do you do if you're invited someplace and you decide, I don't want to go? What do you do if you sleep all day? Or what do you do when you eat all day? All of these are symptoms of depression, or they're symptoms of anxiety that individuals have to learn in their own communities. These are things that are actually commercialized, aren't they? When you see people snacking constantly, nobody really says anything about the fact that, well, that may be eating to comfort yourself. So we have to redefine mental health in our communities and in our families. There's one thing that I think that Pastor Will might have said about involving the family and looking more outside of the individual. We consider that an individual is connected to somebody, and that somebody needs to come into the intervention with them. They may not be biologically connected. That's not the issue. If they trust that person, and if that person will come in, that's family. So we have to redefine the ways in which people benefit from mental health problems. And that's with a connection, particularly if you're African descended or if you're descended from a Latin culture. Being a we person instead of a me person is a sign of mental health. So we need to educate practitioners, we need to educate communities and individuals and families about what mental health should be today in order to live with HIV and COVID.
Thank you. Some great points there. Dr. Musgrove?
Yeah, so I looked at the numbers that we're serving in our mental health program, and at my agency we have 4 licensed therapists who provide mental health counseling to our patients and clients. And right now they're working full time, and we have 50 people on the waiting list. So that really tells you how the need is so great for mental health counseling right now. And usually before COVID, we served around 800 unduplicated HIV persons living with HIV a month. And right now we're serving over 1,000 to over 1,000 people. So our services, our need for services have increased since COVID hit. But the one thing Dr. White was talking about that I kind of really understand is that we moved all of our services, the way that we do services. So our clients don't enter the building anymore. Our social workers actually go out to our clients to keep, COVID out of the building. And we're not having that one-on-one conversation. We're not really finding, getting down into the dirty of really what's going on. Do you have mental health needs? Is your depression exacerbated? Because right now we're just so worried about meeting those frontline needs. We know they need food, we know they need transportation, they need clothes, toilet paper, cleaning supplies. And so I think that what we're going to see is this trend for mental health counseling and programs and support groups are going to continue to increase, because it's just the need is so great, and everybody right now is just interacting at a distance and a very surface level interaction. And it changed just like that. So people who came to our agency every single day and felt like a warm blanket was around them and felt love and support, there's a wall now, and there's a wall with everywhere that they go, even with their family. So I think that is the most significant thing that we are seeing. And so we're going to have to start looking at how do we increase mental health services to meet the needs of our clients and patients a month from now, 2 months from now, and a year from now, because this is our new normal, and we've got to start accepting that. So
that's right. Yeah.
Quentin, would you like to go next?
Yeah, so a couple of things that came up from me talking about mental health. What we've noticed in our clinic, first was since COVID, give you some background, we were serving food supplies as well as housing supplies, essential cleaning supplies. Last year we had about 275 clients in a year. In March, when we made the shift to start providing those supplies, we were serving 400 people a week. We had a lot of people that immediately needed help and needed services. And the reason why we shifted our priorities is because we understood how isolation affects folks, how isolation affects depression, and how just the sense of being, for trans folks, and particularly being affirmed. We have people who, of course, we know didn't have access to medicine. We had some people who were dealing with not being able to access HRT because particularly for trans men or trans masculine folks, testosterone is a controlled substance. You have to have at least one in-person, at that time you had to have at least one in-person meeting with the endocrinologist. So we had a lot of people who were experiencing a lot of depression, increased depression during COVID because they couldn't have access to their hormones. They couldn't have access, weren't able to get labs and prescriptions and make doctor's appointments, but also people weren't able to be affirmed. We had some trans folks who are still living in not the best of situations, where they have unstable living situations, or they're forced to be indoors with families who aren't affirming. So what do you do? What do you do to the 19-year-old Black trans woman who lives at home with their parents, but's not able to get any of the resources or interact with any of the chosen family or friends that they've been able to build a support group with? Those are the type of issues we were facing. How do you support people who can't get out, or who are in situations where they can't change, and while we all are trying to stay in and stay safe? So one of the alternatives, and one of the things that TKO has been doing, we got some additional grant funding to be able to really care for our TGNC folks. And what we decided to do is send out care packages. We started sending out care packages that had binders and bras. It had all of the undergarments. It has makeups and brushes and palettes and razors and all the things that folks would need and normally have access to, but aren't able to get out and get now, either because they can't afford to get out and get it, or they simply just, for whatever, can't have access to it. But making sure that folks have ways to still be affirmed while indoors. I know personally that the South is not the best place to transition. It's one of the worst places to transition. And there's a constant reminder, particularly in faith-based communities, particularly in rural areas, amongst folks who just don't want to change and who always, misgendering is a big issue in the South. And it's one of the simplest things we can do to affirm people. So for us, it was just really, really about making sure that folks felt whole. They couldn't show up whole or get out, just making sure folks were able to bring their whole selves into spaces, even if that just meant being in front of your vanity in your bedroom to yourself, just being able to give folks some peace where we could.
Mm-hmm.
We have a clarification question that came on Facebook. What is holistic healing? Pastor Will, will you address that?
Sure. Holistic healing is really mind, body, and spirit. It's just looking at for us, the entire community, the entire family structure, not just focusing on one thing, but looking at spirit. We can look at culture, upbringing, religious background, different things of that nature. Really looking at the whole being of a person and not just one instance where they may have experienced trauma.
We're going to go to our next question. How does COVID-19 and mental health impact the general population's sexual behavior and access to HIV, STI services? Wahida, would you like us to talk about sex?
Well, okay. So, I come from a very positive, sex positive community, and we've been doing some webinars that were focused on COVID, and the question of sex always came up. Should I have sex? How do I have sex? I think we got some reports from the health department from New York, and I believe from I think it was Oakland also. But people started to share different ways that they were having sex during COVID. And some people talked about going back to old-fashioned phone sex, and that was like one of the biggest things people were talking about: mutual masturbation or something like that, or changing positions during sex. There were a lot of things that came up. The bottom line is people have sex, right? It's not like a pre-existing condition; it's what we do, so that was a concern that came up. And every time we have, in fact, the event that we're having on December the 8th, we're going to talk about sex, and we're having some really great sex positive folks come on and do some presentations for us around sex. But sex has not stopped, and I don't think it's going to stop. But I don't know if people are going to be having sex with masks on and things like that, you know what I'm saying? But people are having sex, and what the report said from the departments of health was that there was a risk of COVID even during sex, because you're deep breathing. There's a lot of deep breathing and you're exchanging aerosol and things like that. So that was what the report put out. And that's why people started talking about and discussing, well, what about this? Or what about that? Well, how about that? And I think the biggest thing that came up was just the safest way was to go back to old-fashioned phone sex. So that's all I had to offer for this answer. I'm going to turn it over to somebody else.
I'd like to add some to that. Aside from those people who are having phone sex, there are people who are becoming addicted to porn because it is available in your home. And as long as you can find it, you can enjoy it and you can become obsessed with it. So I want to stay sex positive, but let me tell you, it is an addiction. It does diminish a person's enjoyment of sex with people, because one day we will have COVID under control and we will be able to relate to one another. We may be relating more cautiously, and that may not be all bad. We may take more time to get to know someone before we get really close to them. But hopefully we will get back to some of those things that are most enjoyable about being around human beings. But porn sex is a problem for people who want to have a relationship. And many times porn sex is more effective because if you're just masturbating, you pretty much learn or know how to do that. When you're having sex with someone else, it doesn't always work out. There's not enough lubrication, or the erection isn't quite firm enough, or there's always something going on, so that you have to make some adjustments. It's not a perfect experience, and it's sometimes really funny, but it's also time consuming and it's anxiety provoking for people who really want to have sex really quick. So as a sex therapist, what I'm doing, and I do virtual therapy, is to give a norm for people, to let them know what real sex is. And real sex is with people, not anything else, not devices. But in the situation, as Wahida said, you have to adjust. But if you're watching porn 3-4 times a day, you are becoming addicted if you aren't already, and you need to stop. You need to read, you need to do other things to entertain yourself that can also stimulate your brain, because porn sex doesn't really allow you or require you to do anything but watch someone else engaging in behaviors that are not always pleasant because they're smiling all the time. That is not real. And, it just gives you a false reality of everyone wants to have sex with you. No, they don't. So it's really not a good thing to become addicted to. You may have a temporary use of it during COVID, but be careful, because once COVID lifts and you can touch somebody again and not worry, you're going to have to work on adjusting to the imperfect human being. Well, that shut everybody up.
Well, thank you. How do you follow that? So we started our STI and HIV testing about 30 days after the COVID hit, and kind of one way that we see trends and we see what kind of what's going on in the community is we do like to follow our positivity rate for STDs and STIs. And before COVID, our percentage rate was around 20 to 23%. It fluctuated. And since COVID, it's around 12%. I thought it would have dropped even much lower. But so it just, the 12%, it tells us that people still are engaging in unprotected sex. They're still engaging in these behaviors, which ultimately will lead us into a path of HIV and the HIV numbers. But I think it really does. Facebook user, wow, that is, you're right. I thought it was going to go down to 0. I don't know what I was thinking, but it does kind of tell us what's going on in the community, and that people are out looking for connections and looking for somebody to talk to and to be a part of, because we're so isolated right now. And I think it just goes back to that question about mental health and how it impacts the general population sexual behaviors. So a 12% positivity rate, that kind of answers that question.
And then Quentin.
I just wanted to add a piece really quickly about some sex workers. COVID-19 has been an amazing provider for sex workers as far as income. There are a lot of new amateur accounts out there of folks who are able to go on and actually make a sustainable income, or at least have something to be able to provide basic resources for themselves for. So I didn't want to shame any sex workers, but I wanted to shout out to the sex workers who have been able to sustain, because sex work is work. One thing we've done to kind of support that is to do within that queer sex ed guide. We have a whole comic strip lined up about, we're going to call it a sex worker safety guide. We're providing our queer sex ed cards that we have. We're putting them in our at-home testing kits. We're putting them in our intimate partners packages that we're sending out. So they have access to lube. They have access to a variety of condoms, not just the standard ones you get from the health departments. We have vegan condoms. We have lubricated condoms. We have flavored condoms, glow in the dark condoms, so that to keep things exciting for folks who are engaging in sexual activity in the midst of the pandemic. So just wanted to shout out some love to the sex workers who are also out there working and being able to sustain during the pandemic.
May I add just a few more things? I understand what you mean by some people need to gain income, but there's some other people who are being forced to have sex because they are living with people who have raped them and who have tried to control them before. And sex trafficking has also increased. So we have to be careful. They may be making money in that situation if they are in control of what they want to do, but there are many women and children who are being victimized sexually and trafficked all over the world during this time, and they have not the usual reporting or supportive agencies willing to come out and try to find them and get them away from those individuals. Domestic violence has increased substantially for people who had at least school or work to get away from individuals, and they're now with them all the time. So it's important to get this history of individuals, if they're having sex, under what circumstance, if they have any opportunity to have communication about their sex lives. Is there anything that they'd like to change? Because people may be reluctant to talk about it if they don't know you and they've never told you about their histories before, or they may know you and they've never shared with you that they're being victimized sexually. So it's an important topic, and it's important to train staff to know how to handle these situations and what the services could be for an individual who may need to get away because they are being harmed. So, we just need to have a very full assessment of what's going on. I think that at the end of the day, what we're saying is you can't really understand how to help people if you just limit yourself to the spiritual life of the individual. They could be praying and joining any kind of church service virtually or on a tablet and being domestically beaten and raped at the same time and not talking about it. It's our challenge to find a way to ask these questions and then to help those people in need. All sex can be good, but it isn't always.
I would just add to that intimate partner violence has increased as well. And so we need to keep this in mind, that it's happening to men as well. Men can be raped.
Absolutely.
Okay. We're going to go to our next question. How does medical mistrust, healthy paranoia of lack of diverse leadership minimize or exaggerate the participation of vulnerable population in COVID-19 related research or trials? And I know we could spend the whole hour and a half just talking on this question alone, but we just wanted to touch it a little bit. And so, Pastor Will, would you take that away for us?
Ooh, that's a loaded question. You're absolutely right, George. We could probably spend a whole nother webinar on this. I'm actually going to yield my time. I know Wahida said she was doing some research and trials. Maybe Dr. Wyatt would be best. We do promote when we get information for folks to participate in research and trials and different things of that nature. And they tell us no because they do not have a trust in our public health system. Mm-hmm. And we even as a faith-based organization really try to get all the particulars to make sure that it is a legit study and all of that. But it's very difficult because people will go all the way back to Tuskegee to recently, just interaction with those currently in the HIV field and being judged or stigmatized, etc. So I'm going to refrain because that's a hot question.
It's not a hot question.
I got to remain pastoral.
Okay.
Pastor Will, I did that on purpose by calling you, because you are in the community and you see this on a daily basis. And as CFAR, Center for AIDS Research, who are on this call, these researchers need to hear this.
Look,
So,
all right, George, you send all emails and complaints to George Kerr there in DC. Leadership is outdated, if you really want to know how I feel. We chase an epidemic. That is not leadership, that's fellowship. Or whatever. Even with the epidemic plan, it's the same folks that have been doing this work for 20, 30 years, getting more money to remodel the kitchen and ain't learned how to cook. That's how I really feel about it. I'm tired of going into spaces, and I'm Black living with HIV. It's a white leader that's telling me how to be Black with HIV, and I'm very capable of telling you how to be Black and live with HIV. It becomes, and yeah, I can say, there is racism within the system. There's white supremacy within the system. It is what it is. But this system was not designed for Black and brown folks. And that's just how I feel. So if we change leadership, then we'll change the trajectory of how we fight HIV. And we need to understand that, we talk a lot about stigma and U equals U and all of these other campaigns where I think they're great slogans. They're not really moving the needle, in my opinion, because leadership is the same leadership that we've had. Here in Georgia in particular, don't necessarily care who's on the call that hears me say this, because I say this, anytime that I do speak, our leadership remains the same. And our numbers, since I've been doing this work now for 11 years, our numbers increasingly get higher. And the only thing that I see also getting higher is their salaries to fight an epidemic that they have no intention to end. That was George's fault. And enough said.
I think it was terrific.
I'm going to now pass it to Wahida for her to get me in more trouble.
Everything that Pastor Francis just said, I agree with. Black and brown people suffer health disparities, wealth disparities, housing disparities, quality education disparities. And we always scream Tuskegee. Nobody really knows what Tuskegee is or what it was. I'm happy to say I had the opportunity to go to the CDC and actually see the paperwork that said stop the study for Tuskegee. And then here in Pennsylvania, in Philadelphia, we have the University of Penn, who's known for the Acres of Skin, who's known for the researchers who went into the prisons and did a lot of research on Black and brown people in the early days. So there is a lot of mistrust. And I think it's generational, because everybody says that nobody wants to be the quote unquote guinea pig. So I also work around HIV cure research, same thing. Black and brown people have a distrust. They don't believe, first of all, Black and brown people don't believe they're going to be the first ones in line to get any sort of like real cure or anything anyway. And there is a distrust. How do we get around it? I think it's trying to just be as transparent. The University of Pennsylvania has tried to be transparent, and every year here in Philadelphia, they give some kind of forum and they admit the mistakes that they've made within the Black community. They run this picture. They run the book. I forget the professor's name, the researcher's name, but he wrote this book called The Acres of Skin, and he went into the prison system in Holmesburg up here and just used everybody and gave them a couple little dollars for money on their books to be able to run all of these experiments and stuff. And a lot of people got really messed up with that. So it's a long road. It's a long road, and what Penn is doing, like with myself and a couple other of my peers right now, when it comes to HIV and depression, they have asked us to come on for about a month to see if we could help recruit. And when it went down to, they actually put us in, like, I actually work for the University of Penn now, a job I never put an application in for. I mean, they want me to put in money in my retirement. I'm already retired. But just saying, it's a hard road because we're very distrustful. And I always try to tell my people, when I say my people, people of Black and brown people like me, you know, we're lucky that the aspirin works. We're lucky that the Tylenol, it just happens to work. I don't think we were in that study either, but we're taking medicines. We're benefiting from other people being a part of studies, and that I try to and do encourage people that we have to get involved in studies so that we know that these medicines work for us because we've been in the studies. So we've been like pretty lucky that things just happen to work for us. But I think that the universities have a long way to go in developing trust in the communities and just to be transparent.
Dr. White, can I ask you to give your comments, to keep it to about 1 minute, because we are starting to run out of time. And I know that's very difficult to do.
Well, it is, because this is my issue. I'm a person of color, always have been, and proud of it. And I do not see in the leadership, and have not seen in the leadership, particularly the trials, any diversity. I've seen training programs for diverse people coming out of postdoc PhD programs, but I still see the same people leading all the studies. I don't see the diversity. I'm very glad this group has been established. I think that's progress. But will they listen to you in terms of your hesitancy to participate in trials because you want to know who is leading the trial? That's what I was asked when someone called me and said, would you refer your participants to our studies? This new COVID trial or this new vaccine trial is coming out, and we need so many Black people. I said, absolutely not. First of all, I should be running that study, not participating in community recruitment. I don't know who's running it. They've never called me. And why should I refer people to something? I'm not the nurse in the Tuskegee study or in the movie or the play that encouraged those poor men to continue in that study even after penicillin was discovered. I'm not that person. I think that if you are concerned about speaking out right now and you're on this panel, something is wrong. Your people are being manipulated. They're being used in studies. We know it now. We know the history of this, and we're still participating? No. They need to step back. They don't know. The reason we're not making the progress in the Black community is the people making the decisions are not Black. They're not expert. They don't do research. And yet they are making money off of Black people, Black and brown people. That's my feeling as a person who has directed studies and will continue to do so. But I wouldn't ask any gay person to participate in a study looking for gay people unless I knew about their ethnicity and their life and their cultural beliefs and religious beliefs and made sure that the principal investigator understood those issues or represented those issues themselves. Then why is it okay for white people to run all these studies and to have a group like this on the side? And yet, what kind of role do you play in helping to select the principal investigators of any study? When do you get an opportunity to say that person is not qualified? They have never worked, they have nothing to do with our community, and they don't know anything about the history of our people. If we don't stand up for ourselves, who's going to stand up for us? I know George told me to keep it short. I hope I've done that, but I got a chance to make those issues. Medical mistrust isn't going to go anywhere until we don't have any reason to worry about what we're being given, who we're being given it by, and what is it supposed to do. Healthy paranoia is healthy because we should be distrustful. You should ask questions and you should demand representation at all levels. Otherwise, HIV will be here when we are gone.
Thank you. Very powerful and much needed to be said. Our final question is a call to action, and we've asked each one of our participants to give us 1 to 2 sentences on a call to action on what you would like the faith community to do during this COVID-19 crisis. And so I'm going to start out with Quentin.
Call to action for the faith community. For us, for me, speaking from my experiences and from my platform as a person of trans experience who has developed an organization fighting for folks like myself, What I'm asking, my call to action for the faith community is to not forget the breadcrumbs. I haven't always been into the church or heavy into the church, but somewhere in there in the Bible, there was a meeting on the mountaintop where Jesus asked them to gather the breadcrumbs to feed a multitude. Now, I can't tell you what scripture and what chapter it came from, but I know the story. And the point that I want to make is that my organization started as a breadcrumb movement. We were an organization who started out to get those who were left behind. So as the churches are progressing and we have the faith leaders who are being more progressive and looking towards the future, my call to you, or my call to action is, for me, I'm asking that you please don't forget about the breadcrumbs. Don't forget about those of us that have been thought less of, but we may be the very ones you need to help feed and instill the rest of us in the future. So don't forget about the breadcrumb folks.
Dr. Musgrove?
Thank you. I would love for the faith-based communities to engage and to learn about how to provide LGBTQ affirming counseling and programs. That way they can work with the HIV community and the programs that we're doing, but we would have a safe place to send our clients and patients. Right now, I think that that's just kind of a missing gap. Some of our patients and clients are afraid to engage into the faith-based community and get the free counseling and the services that are provided. And I would love to be able to feel comfortable to refer people. So we need to work together to find ways to make affirming programs to where I feel safe enough to refer them. Become collaborative partners.
And Wahida?
Yes, I would refer our faith communities to Matthew 27, I think it's 25 through 30, where Jesus is saying to his disciples that when I was hungry, you fed me, and when I was naked, you clothed me, and when I was sick, you came to visit me, and when I was in prison, you came to visit me. And those disciples said to him, how could we do this for you, Lord? When you're Lord, how can we do this for you? And Jesus said to them, well, you did it for the least of mine. You did it for me. Mm-hmm. And so, and I have another proverb that I say to Muslims. It's the same thing. Our mandates and how we respond to people's illnesses, regardless to what they are already written in our holy scrolls for us. So I would just say read.
Dr. Wyatt?
I can't impress upon you how thrilled I am to have been asked to participate today. You've done a great job, panel. If no one else says it to you, I say it. I salute you for being strong enough to come out and talk about religion. So what I'd say is the religion is extremely powered to people of African descent, to those who are disenfranchised and marginalized, affected by, at risk for. And that research needs to incorporate these concepts by allowing people who have the lived experience to provide expertise in knowing how to deliver interventions that are quite different from what we are providing today. It's a challenge, and they need to step back and let us step up and take it.
And Pastor Will you wrap it up for us?
There we go. I think not only faith leaders, but all of us just need to be more transformational and less transactional would be my call to action on today.
Thank you so much. We really appreciate all of your conversation. And I am now going to turn it over to our fearless leader, Robin.
Well, thank you. I just have to say, wow. Just wow. I am so inspired. We have our call to action now. Let's act. I am thrilled to co-direct the UAB Center for AIDS Research, Behavioral and Community Sciences Core. And on behalf of the Inter-CFAR Faith and Spirituality Research Collaborative Webinar Series Planning Committee, I'd like to thank you, Dr. Wyatt, for doing so, but thank the UAB DC-CFAR for hosting this wonderful platform. You probably can't tell, but because it's been so smooth, but Kenya Hutton is behind the scenes doing such an amazing job being our production specialist. And so thank you, Kenya, for that. And thank you to our co-moderators, Elder George Kerr and Edward Jackson, as well as our esteemed panel members. I think we could probably go on for another full hour with just so many more messages to be shared, calls to action, and more findings about research. We've just been so blessed to hear these great insights and experiences and research on the traumatic experiences of living with HIV, particularly now during COVID-19, and how the faith and spiritual community can be a source of strength and support. So thank you all for joining. We're looking forward to celebrating our Inter-CFAR Faith and Spirituality Research Collaborative webinar series on December 4th. So we hope you can join us for that. And then for part 2 on mental health, HIV and faith and spirituality in January, we'll kick off our new year focusing on stigma. So please join us for that. And we so appreciate you for joining us today. And now we'll hear from Kalani.
You're muted.
Hello. Hello, everyone. My name is Kalani Upshaw, and I'm Americorps Vista Opioid Addiction Prevention and Education Fellow at UAB School of Public Health. I would like to thank all of our panelists and moderators for participating in today's webinar on faith, HIV, and mental health during COVID-19, provided by the Inter-CFAR Faith and Spirituality Research Collaborative Fall Webinar Series. If you missed part of today's discussion or would like to watch any of our previous webinars, you can access them at the UAB CFAR Behavioral and Community Sciences Core YouTube channel. For more information on upcoming webinars, events, and HIV research, please follow us at UAB CFAR BCSC on Facebook, Instagram, and Twitter. For more information on the Hub in Atlanta, Georgia, follow and reach out to Pastor Will Francis at Elder Will Francis on Facebook, Instagram, and Twitter as well. Now we will end with a closing prayer by Pastor Will Francis. Thank you.
Thank you all. Great job, and thank you for the opportunity. We started this journey, this conversation today with this time to heal. So let us just close with let's. Thank you, and have a great rest of your week.
Thank you all. Have a wonderful rest of your day. And thank you again for joining us. Bye-bye.
Bye-bye.
Absolutely. Thanks, everybody. Thanks, George, for inviting me. Everybody take care.
Thank y'all.
Thanks, Rob.